Hello everybody. Today I'll talk about the cardiovascular system. We started in last class. We'll continue on the cardiovascular system. In last class I talked about the anatomy of the heart. Today I'll talk about the physiological properties of the heart muscle or cardiac muscle, mechanism of contraction of heart muscle, conductive system of the heart, regulation of heartbeat. There are two types of controls or regulations. One is nervous, another is hormonal. So we'll talk about the nervous and hormonal regulation of the heartbeat or heart rate, and then we'll talk about the electrocardiogram or EKG, which is a recording of the electrical activity of the heart. Then we'll talk about few clinical conditions. First, the properties of the cardiac muscle. Cardiac muscle has contractility, the ability to contract. So contractility is the ability to contract. So heart muscle contracts. Autorhythmicity. Auto means self, and rhythm, beating in regular interval, maintaining an interval. So the heart beats by maintaining an fixed interval between them. So the ability to contract by itself or beat by itself is autorhythmicity. And conductivity. Inside the heart, you have conductive tissue structures formed by conductive tissue, and because of those conductive tissue structures, your heart has the conductivity inside it, and that controls the heartbeat. So the conductive tissue forms conductive system, and the conductive system regulates the heartbeat. Heart beat or heart rate. Okay, we'll talk about that. Then cardiac muscle acts as a syncytium. What is that? Syncytium means unit. So all heart muscle fibers in a chamber work together, and that gives the heart muscle to contract quickly and strongly. Then how the heart muscle fibers work together as a syncytium or as an unit. You must remember when we talked about the histology of the cardiac muscle, you know that cardiac muscle fibers are cylindrical fibers. So these are the fibers and intercalated disc. So intercalated disc is the place where the heart muscle fibers are attached to each other. So this is another intercalated disc. This is another heart muscle fiber. Okay, so intercalated discs attach the muscle fibers. Now, in the intercalated disc, you have two types of junctions. One type of junction is gap junction, and another is desmosome. You must remember from ANP1, we talked about these junctions. Gap junctions, if you see here, uh, in gap junctions, there are channels or pores. So what happens? The ions can quickly move from one fiber to another. So since there are gap junctions here in the intercalated discs, the ions like sodium, potassium, calcium, they can move quickly from one cell to another. So the doors are open, the channels are open because of the gap junctions. So if any change occurs here, it will quickly be transmitted to the other cells. Okay, that is one way the heart muscle fibers are chemically connected. The ions quickly move from one to another. They are not separated. Desmosomes hold the heart muscle fibers very strongly, like zipper in your cloth. So the desmosome is a very strong junction that holds the muscle fibers very strongly to each other. So because of these two types of junctions, intercellular junctions in the intercalated disc, all heart muscle fibers act together like an unit, and that function is called syncytium, contracts as a unit. Absolute period. Uh, Better instead of absolute if we say refractory period. I prefer that term. Uh, refractory period. So you can change it uh, to refractory period. What is that? Uh, when you stimulate the cardiac muscle shows contraction. During the contraction of the heart muscle, heart muscle contracts and relaxes, right? So if this is the contraction and this is the relaxation phase, so this is contraction and this is relaxation. Okay, during the contraction of your heart, if you give a stimulus, any stimulus comes from outside of the heart or can be created inside the muscle of the heart. If a stimulus arrives or given, heart muscle will not respond to this stimulus. Now, during the first 200 milliseconds, so if this is the whole, uh, cardiac cycle, that means contraction and relaxation, during the first 200 to 250 millisecond period, like this time here, this is 200 to 250 millisecond. During that period of contraction, that means first part of contraction, if you give a stimulus to the heart muscle will completely ignore it, totally ignore it, will not respond at all to that stimulus. Even if that stimulus is strong, heart muscle will not listen to it. and that period 200 to 250 millisecond, when the heart will not respond to any other stimulus, it will continue contraction, its own contraction. That is called the relative absolute refractory period. Absolutely not listen, absolutely no. Okay, will not respond at all to any other stimulus, which is very important because during this first part of the contraction of the heart, most of the blood, 80% of the blood is ejected. So if just think that if heart responds to another stimulus during that time, then the blood will not be able to get out. Heart will stop briefly, right? So that should not happen in case of your heart. So heart will not listen, and that is the absolute refractory period. Now, during the last part of contraction, the end part of contraction, if you give a stimulus and the stimulus is strong, heart may respond. So heart, if the stimulus is weak, heart will probably ignore. If the stimulus is strong, heart may respond. So that last part of contraction is called relative refractory period. That means it may or may not listen, may or may not listen or respond during the last part of contraction. So that's why it is called relative, depending on the strength of the stimulus. Elasticity, the ability to recoil. You can expand the heart muscle by pressure. However, uh, when the pressure will be gone, it will recoil, and that happens every time when heart beats, right? Heart expands and recoils or contracts. So that is the elasticity. There is a law that applies to the heart muscle tissue. What is that law? That is called Frank-Starling law. That law tells that within a limit, physiological limit, the length of the muscle will be proportionate to the pressure or tension. So if you increase pressure, it will get longer. If you pull or put more pressure, it will get more elongated. However, uh, if you keep pressure, very strong pressure for a long time, heart muscle may lose its elasticity. It's like the elastic thing you use in your cloth. When you are skinny, you used to use that, cloth. But now your body size has increased. You are now big. If you keep using the same cloth, then eventually, due to excessive pressure for a long time, the elasticity will get lost. The elastic thing will not recoil, will not go back to its actual length again. So that is applicable to the heart muscle. That's why it says within a limit. If you cross the limit, it will lose the elasticity. But within the limit, if you increase the pressure, the length will be more, and when you leave the pressure, it will go back to its actual shape. However, if that limit is crossed, then heart muscle will lose the elasticity. That means the heart will remain big. It will not be able to recoil, and that is called heart failure. Failure. And in heart failure, what happens? The heart muscle cannot contract. The heart is big and remains big, large. So the size of the heart remains big and it is not um, able to contract forcefully. That is the heart failure. The elasticity is lost. Now, to understand the cellular mechanisms of cardiac muscle contraction, you have to understand the depolarization and repolarization. That means the action potential in the cardiac muscle potential in the muscle fiber, heart muscle fiber. Muscle fiber or muscle cell, same thing. So, if you see inside a cardiac muscle fiber, in all the cells of your body, inside is always negative in resting condition. Okay, so inside is negative, and that is the voltage inside the cardiac muscle fiber or cell. And remember, uh, outside of the cell of your body, everywhere in extracellular fluid, the concentration of sodium is high. Sodium is positive ion and concentration is high outside. And inside, the concentration of potassium is high. So here the concentration of potassium is high, and potassium is also positive. Okay, now when the heart muscle, you know, decides to contract, what happens? The sodium channels in the cell membrane get opened, and these are voltage gated sodium channel. That means open very fast. So now you know sodium is concentration is high outside, that means low inside. So we always know that the chemicals move from high concentration to low concentration. So sodium will get in from outside to inside. Okay, so now if before sodium enters, that is called the resting condition or resting membrane potential. Inside, we are always looking inside the cell or fiber. So before sodium gets in, that is the resting condition, resting membrane potential. Okay, and it is minus 90 millivolt, negative always. Okay, now sodium channels got opened, and these are voltage gated sodium channels, so abruptly they will open, and a lot of sodium will quickly get in because sodium concentration is high outside. So now if I draw this way positive inside and this way negative inside the muscle fiber, if sodium gets in, sodium is positive, right? So inside the cell or fiber, the positivity will increase. So it will move towards positive. So that is the, and very fast, because a lot of channels will get opened quickly. Okay, so that is called depolarization. Depolarization. Okay, very important. So it will go towards positive very fast. And then next what will happen, the sodium channels will start to get closed. Okay, and potassium channels will start to get opened. So potassium will start to get out because concentration of potassium is high inside, right? So potassium, when channels will get opened, potassium will get out from high to low. So now you see potassium is also positive, so potassium is getting out, but something else happens at the same time. Calcium channels get opened, so calcium gets in. So these two things happen together. So calcium is also positive. Okay, so you see calcium is getting in, that means positive is getting in, and potassium is getting out, that means potassium is getting out. So they will cancel each other. Positive getting in, positive getting out. So since those two things are happening together, the membrane potential, that means inside the muscle fiber, the voltage will not change, because potassium at the same time getting in and out. So it will stay like same for a while. Okay, then calcium channels will get closed, but more potassium channels will get opened and more potassium will get out. So what will happen now? Only potassium is getting out, right? So positive is only getting out. So the membrane potential or voltage inside the fiber will move towards the negative, because positive is getting out. And this part, when the voltage inside the muscle fiber remains steady, not changing much, this is called plateau. And then this part, when the calcium channel get closed but more potassium channels get opened, that means more potassium will get out, positive get out, it quickly goes down, and this part is called repolarization. Okay, so depolarization due to influx of sodium, so inside will be positive. Plateau is due to calcium and potassium. Calcium in, potassium out together. Calcium in, potassium out. So that's why no change this part. And then calcium will get closed, only potassium channels open more, so potassium efflux or outflux. Say efflux of potassium out. Okay, so that causes repolarization. So now, why these are important? You see, depolarization gives the heart muscle a signal to contract. So immediately after depolarization, contraction occurs. Okay, and then plateau tells the heart muscle stop contraction but remains there for a while, and then repolarization tells the heart muscle to relax. So you see, depolarization is causing contraction, plateau is giving this interval like it's not contracting or nor relaxing. So this is an interval due to plateau, and then repolarization causes relaxation. So this is contraction, pause or interval, and then relaxation. Okay, and that happens all the time in the heart. Contraction due to depolarization, which is called systole, right? Contraction or systole, then interval due to plateau, and then relaxation or diastole. Okay. Now, this interval given by plateau is very important because heart should not relax immediately after contraction. When contraction occurs, blood gets out. But if immediately after that relaxation starts, then some blood will get back. So to prevent that, there is an interval between contraction and relaxation, and that's why plateau is very important. Okay. Here, you see what I explained. If you see here, this is the number one is depolarization, very sharp going up, and then this is plateau, remains almost not much change, same, and then that is number two, and repolarization is this one, number three, and this is contraction, showing contraction. This is interval here, and this is relaxation. Okay. So now if you read here what I said, you will understand exactly same thing. We talked about autorhythmicity. Now that is the heart muscle contraction, interval, relaxation. However, in case of the conductive tissue, inside the heart, there is a structure that is called the pacemaker. Pacemaker is a structure formed by the conductive tissue. Uh, so you probably have heard the pacemaker. It controls the heart rate. And if you see the depolarization and repolarization of the pacemaker in that special type of tissue inside the heart, which is different than the depolarization and repolarization of the heart muscle. In case of heart muscle, you have seen that depolarization occurs very fast, straight, like almost straight up, very fast. But in case of pacemaker, the depolarization occurs slow. Particularly, you see the first part of depolarization is really very slow. Okay, slow rise. That means inside the pacemaker cells, the sodium channels get opened slowly because these are not voltage gated sodium channel, non-voltage gated sodium channel. Okay, they open slowly. That's why the depolarization first part is very slow, and then when it reaches to a certain limit, that is called the threshold. So this is the threshold. So when the depolarization arrives at threshold, which is about minus 40 millivolt, uh, in resting condition in pacemaker it is not minus 90, it is around minus 60, and when it moves towards positive, this way positive, right, and sodium is getting in, so when it reaches at this level at threshold, then more channels open suddenly, and rest part of depolarization is completed. And then uh, here you see there is no plateau, and then repolarization occurs due to the opening of potassium and outflux of or efflux of potassium. So no plateau here, no plateau here in case of pacemaker, but in case of heart muscle you have seen plateau here. Slow depolarization, right, slow depolarization. In case of cardiac muscle it was fast. And another thing you see that here after it returns to the resting potential. Then again deployation starts, but again it is slow. And this part, the slow first part of deployation, this part is called pacemaker potential. And this pacemaker potential is very important to give interval between two heartbeats. You know, your heart beats, then there is a pause, then another beat, then there is a pause, there is another beat. That rhythmic interval is given by this pacemaker potential. If you see it ends here and then again it starts another one, then the heart will not get enough interval. After end of one beat, another beat will start immediately and your heart rate will be very high, right? But that is not the case. There is an interval because of this. Now if I can make this interval short like this, then another beat will start early. Make sense? And if I can make this pacemaker potential slow, like it goes like this, then another beat will be delayed. So you can make the interval short by making the pacemaker potential faster, and you can delay the interval by making the pacemaker potential longer or slower. So the interval between two beats will be faster here and slower here. And you know, uh, when your heart rate increases, this interval gets shorter. When heart rate is slow, then interval, pacemaker potential interval gets longer. So this is how the heartbeat um, can be changed. There is a condition that is called, fight or flight response. Your heart rate increases, right, due to adrenaline secretion and sympathetic activation. In that case, this happens. The pacemaker potential gets, uh, faster. So the interval gets slow and heart rate increases. Now, during parasympathetic stimulation, like release of acetylcholine, another chemical, the heart rate gets slower. Uh, so the pacemaker potential will be longer. Makes sense? So there are medicines, if someone has tachycardia, heart rate is fast always, then you take the medicine that will make this one longer interval. So the heart rate will be slow. Conductive system of the heart. As I told you, inside the heart, you have highly special tissue structures. So those structures together called the conductive system of the heart. In the conductive system, there are two nodes, okay, tiny round structures formed by highly specialized cells, and those are SA node or sinoatrial node and AV node or atrioventricular node. SA node is called the pacemaker. You have heard this term, pacemaker of the heart. Why it is called the pacemaker of the heart? Because in normal healthy heart, SA node controls your heart rate. Heart rate, okay, or heartbeat. That means what? Pacemaker, um, it's like a battery. It produces electrical impulse one after another at regular interval. So every time pacemaker produces an electrical impulse, your heart beats. So if your pacemaker produces 70 impulses per minute, 70 times per minute, then your heart will beat 70 times. So every time pacemaker produces an impulse, that goes to the wall of the heart and heart beats. Okay. Normally, pacemaker produces between 70 to 80, and that is the normal heart rate, right? AV node is a backup. If SA node fails for some reason, if SA node is destroyed or damaged, non-functional, then AV node takes over. But SA node is the main one, right? So if SA node is absent, it's like, in the office, this is the main boss. If he is gone, then the second one takes over. However, the second one is not that efficient, and AV node can produce impulse, however, at a slower rate, 50 times per minute. Okay, slower than SA. This is SA, this is AV. So in that case, your heart rate will be 50 per minute, so slower. However, the heart will function, and the person will survive. And if the doctors recommend, then in that case, the patient takes artificial pacemaker implanted in the heart. So artificial pacemaker is like a battery that will produce the impulse, and you can adjust the uh, rate of impulse in artificial pacemaker. And then so those are two nodes, and there are also the structures, other structures. Those are actually bundle of fibers, so fibrous structures. So two nodes and fibers, those are the structures of the conductive system. So conduction system or conductive system, same thing. Conductive system includes two nodes, SA node and AV node, and the fibrous structures. So we'll see what are those fibrous structures. AV bundle, which is also called bundle of His, right and left bundle branches, and Purkinje fibers. So those are the structures. Now, if you see here, this is the conductive system of the heart. So this is the SA node located in the upper part of the right atrium. So this chamber, you know that this is the right atrium here. This is the right atrium. So both SA node and AV node are located inside the right atrium, but SA node is in the upper part of the right atrium, where the superior vena cava enters into the heart. So near the entrance of the superior vena cava, SA node or pacemaker. And AV node, its name is AV, atrioventricular, so close to the AV valve, right AV valve, tricuspid valve is here, right, close to that. So that's why it is called the AV node. Now, from SA node to AV node, how the signal, electrical signal goes. There are fibers, those are called internodal fibers. Inter means in between, right? Internodal fibers take the signal, electrical impulse from SA node to the AV node. And also, when the electrical impulse is produced in SA node, the signal spread to the wall of the atrium. Then AV node sends signal through the bundle of His or AV bundle. So this part you see from here to here, This part is called the AV bundle, this one. And then you see the AV bundle is located in the upper part of interventricular septum. This is the interventricular septum between right and left ventricle, the partition. So the AV bundle, which is also called bundle of His, or AV bundle, located in the upper part of the interventricular septum. Then what happens? It divides into two branches. So these are called the bundle branches, right and left bundle branches. Okay, and these bundle branches go all the way down to the lower part of the interventricular septum, and then the left one goes to the wall of the left ventricle, and right bundle branch goes to the wall of the right ventricle. And in the wall of the ventricle, they give branches, and these are called the Purkinje fibers. Okay, so those are the parts or structures of the conductive system of the heart. And conductive system does what? Generate, generates and transmits electrical signal. So generates and transmits what? Electrical signal. You know that SA node and AV node, they generate electrical signal. SA node at a higher rate, AV node at a lower rate. Okay, and transmission is done by the fibers structure, bundle of fibers. So that's how the electrical signal is transmitted to the wall of the heart, and that is the electrical signal you record in EKG or ECG, electrocardiogram. In most part of the world, they use the term ECG, electrocardiogram. Here we mostly use the term EKG, electrocardiogram. Okay, so electrical activity that transmitted throughout the heart, and that electrical activity, it's electricity, so it will get out from the heart and will be transmitted throughout the body. And that's why if you place electrode anywhere in the body, you can pick it up, this electrical activity, from anywhere in the body. Okay, now if I told you that if the SA node is destroyed or become non-functional, then what will happen? You see, the atrial wall will not get electrical signal. Ventricle will take over the function and will start to produce the electrical impulse at a rate of 50 or even less, and that signal will go to the wall of the ventricle. Okay, so heart rate will be slower. Now, the heart block, the term we hear, heart block. Heart block is not the block of the artery of the heart. Heart block is the blockage of the electrical signal that travels through the conductive system of the heart. Okay, so don't get confused. Arterial block is a different thing. Heart block indicates not the arterial block, but the blockage of electrical signal transmission. If any part of AV node is damaged or destroyed, then the transmission will be slower here. When the signal will try to pass through it, it will be slower and weaker, right? So the ventricular wall will get less delayed and weak signal. So that is called partial heart block. If it is completely destroyed, then the ventricular wall will not get any signal. That is In that case, we'll say complete heart block. So this is normal EKG, the electrical activity that is produced and transmitted through the conductive system, and then transmitted everywhere in the body. So you can record the EKG. EKG has three components. So if you just take one, like let's take one that starts, hold on, here to here. This is one. Then this is another. So this is each EKG tracing. So let's see what are the components there. You have a wave like that, the first one here, this one. Then you have a big one like this, and then you have another small one. So three, you see one, this is the big one, and this is another smaller one. So this first one is called P wave, this one, and then this one is called a complex, QRS, complex, this one, big one, QRS, complex. And then this one is T wave. Now P wave, this one, P wave is due to atrial depolarization or contraction. You remember I said depolarization causes the contraction. So depolarization, or we can say atrial contraction. Okay. Then QRS, this big one, QRS is ventricular. You know, ventricle contracts more forcefully than the atrium, right? So ventricular depolarization or contraction. Ventricular depolarization or ventricular contraction. And then T, this one is ventricular repolarization or relaxation. Now you see, three components represent three things: atrial contraction, ventricular relaxation. So which one is missing? Atrial relaxation is missing. After atrial contraction or depolarization, there should be atrial repolarization or relaxation. Atrial repolarization is missing in EKG tracing. Why is that? Because you see here, this is P wave, atrial contraction, then after that atrial relaxation occurs, right? However, when atrial relaxation occurs, at the same time ventricular contraction occurs, and atrial relaxation is very weak, and ventricular contraction pumps the blood to the outside of the heart, right? So it is very strong contraction. So this one is buried in the ventricular contraction. So that's why you don't see, since they are happening together. So it is, that's why the stress is a combination of two, but this one mostly represents the ventricular contraction, and that's why it is called a complex, QRS complex. Others are waves. Okay, so this is normal. Now here you see something is missing. P should be here, then QRS, this is QRS, and this is T. So which one is missing here? P. There is no P here. There is no P here. Why P is missing? If S node is non-functional. You must remember I said that S node gives signal to the wall of the atrium. So if S node is non-functional, then atrial wall will not get any signal. Number one. Number two, ventricle AV node will take over, so heart rate will be slower. So those two things you will see if SA node fails. P wave will disappear because no atrial contraction, and now AV node is producing impulse at a slower rate, so heart rate will be slower. So those two things happen. Here you see P wave is not here, absent. This one is missing, that means atrial contraction is missing, and the interval here will be longer because heart rate is slower. Okay, so at a rate of 40 to 60, that means average 50, which is uh, the rate of the AV node. So we classify the heart block in different criteria. So one criteria is called uh, degree of heart block. First degree heart block, second degree heart block, and third degree heart block. First degree heart block if SA node is non-functional. Second degree heart block is if the AV node is blocked, like signal is blocked here but partially blocked. Okay, so that is second degree heart block. So some signal will be able to pass through and will go to the ventricular wall, but that will be weak and slow. So that is second degree. Now if the AV node is totally damaged or non-functional, that is the third degree heart block. So ventricle will not get any electrical impulse, will not be able to contract. So third degree heart block is actually like close to um, death. The person is actually close to death. So first degree heart block, second degree heart block, third degree heart block. Abnormal heartbeats. The heartbeat could be abnormal in different ways. You know that normal heart rate is 70 to 80. So this is normal heart rate, healthy heart rate or heartbeat. And you see the interval is maintained between the beats, right? So 70 to 80. Let's say 70 per minute. So this is normal. Now, if the heart rate in resting condition gets fast like this, so in this case the heart rate is much higher than this one, right? This is higher. So if that happens in resting condition, when you are in resting relaxed condition, if it is high, that is called tachycardia. Tachycardia, sorry, or cardia. Okay, so that is one condition. You see what happens, the heart beat is much faster than the normal heart rate, right? That is one clinical condition that is called tachycardia. Okay, now there is another, so this should be a tachycardia, increased or higher heart rate, faster. If the heart rate is slower than normal, this is normal. If the heart rate is slower, okay, than normal, this is called bradycardia. So this is normal heart rate in resting condition. This is faster heart rate in normal resting condition, that is called tachycardia. and this is slower in resting condition, slower than normal, that is bradycardia. And another type of irregular heartbeat or abnormal heartbeat is, here the intervals, although heartbeat is slower, but interval is maintained. Here also intervals are maintained. However, there is a clinical condition in which the interval is irregular too, like heart is beating fast, but sometimes beating very fast, then gets slower, then is strong, weak, 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 then is strong, interval gets longer, then short interval, weak, right? So highly irregular, chaotic heartbeat, that is called fibrillation. So this is also abnormal heartbeat, and this is called fibrillation. Highly irregular, uh, chaotic heartbeat or heart rate. So another is, like you see, that is called ectopic focus. What is that? This is your normal heart rate, heart is beating, heart contraction, then this is another contraction, and during contraction, if your heart, if any extra premature beat occurs, like here is extra beat during contraction, or during the interval you see an extra contraction, then the regular contraction, then again an extra tiny contraction, then regular contraction. So these are called premature contraction and ectopic focus. Extra beat, extra weak, tiny, premature heartbeat. And all these irregular heartbeats, tachycardia, bradycardia, fibrillation, ectopic focus, these are all, all these belong to abnormal heartbeat, and that is called arrhythmia. So arrhythmia indicates irregular heartbeat. It could be any kind of irregular heartbeats. Altogether, in general term, we say arrhythmia. Uh, Here, blockage, we talked about the heart block, partial block, complete block, first degree, second degree, third degree. We have already talked about that. Uh, Let me quickly explain again. This is your heart, right? So this is the heart. Here you have uh, the right atrium, SI node, AV node, interventricular septum is here, right? And ventricular wall. So you know that from SI node signal goes to AV, then AV, from AV through the um, AV bundle, then bundle branches right and left, then to the wall of the heart. So if SI node is non-functional, that is first degree heart block. If AV node is partially damaged or blocked, that is called the second degree. So some signal will be able to pass through and go to the wall of the ventricle. So that is second degree heart block. And if AV node is completely non-functional, that is third degree heart block. Okay. So uh, there is no definitive, boundary which one will be considered as first degree, second degree, third degree. But considering the condition of the heart, the doctors determine which one is belongs to first degree, which condition should belong to second, and which condition should belong to third degree heart block. Now, regulation of heartbeat. Your heart rate, that means the impulse produced by the AC node, and this is the AC node or pacemaker, and uh, how many impulse the AC node will produce, that is controlled by the autonomic nervous system, the motor autonomic control. It is a branch of motor uh, nerve or motor division. So autonomic nervous system has sympathetic and parasympathetic, you know that. So sympathetic gives the fight or flight response. So sympathetic will give the uh, signal to the AC node that will increase the heart rate and increase the force of contraction. So the heart rate will go up, and also the heart will be pump more forcefully. That is called force of contraction. So both will be increased by sympathetic drive or activation. That is called positive inotropic, positive chronotropic. Uh, Anyway, so you know what happens when you get excited or fight or flight response. Your heart rate increases as well as your blood pressure. The force of contraction, your heart beats very, strongly and fast. So that is sympathetic. Parasympathetic is inhibitory signal to the AC node. Will slow down the AC node, so the heart rate will be less. So decreases. So parasympathetic is another division of autonomic that will decrease the heart rate and decrease the force of contraction. That means decreases the blood pressure. Okay, so that's how the autonomic nervous system, its two divisions, sympathetic and parasympathetic, uh, controls the heart. Sympathetic works through the chemical that is called adrenaline and noradrenaline, also called epinephrine, norepinephrine. You have probably heard adrenaline when you are excited. See, the movie has a lot of suspense. The adrenaline is released, right? We say, and parasympathetic by acetylcholine. Now, uh, here you see this is the heart, and this is the AC node, AV node, and wall of the heart. Let's see where the centers are located that send signal to the AC node and other areas of the heart to control the heart rate and force of contraction. So in the brain stem, medulla oblongata, in the brain stem, pons medulla, you must remember. So brain stem has medulla oblongata, and in the medulla oblongata you have the centers, cardiac centers. Cardiac centers. Okay. One center is called acceleratory center. It's like accelerator of your car, and another is inhibitory signal, is like the brake of your car. So uh, when cardio-acceleratory center is activated, then it sends signal through the sympathetic nerve, because we know that this is the cardio-acceleratory center here. So the yellow color, this is the parasympathetic, sympathetic. So that will uh, excite the heart. So this one, the yellow one, brings signal here to the spinal cord and gives signal to another set of neurons, the green neuron, and that will go through the ganglion, sympathetic ganglion, this one, and then to the SA node, AV node, you see the green one, and wall of the ventricle. So anyway, so acceleratory center will excite the sympathetic nerve, and that will excite the heart. And this is the cardio inhibitory center here. That one will send signal through the parasympathetic, and in case of heart, the parasympathetic nerve is the vagus nerve, cranial nerve number 10. So that is the parasympathetic vagus that will inhibit or slow down the heart. So will decrease the heart rate, decrease the blood pressure or force of contraction. So that's how the heart rate and force of contraction or blood pressure are regulated. Electrocardiography or EKG or ECG, I have explained 3 components of it and which one is for what. Now, when we see or read the EKG, we see 2 things. One is the interval, the duration of each component, how much time the P wave took, how much time the QRS wave took, what is the interval between P and QRS, how much time the T wave took, what is the interval between these. So we know the normal range, so how much time the atrial contraction should take, and after atrial contraction is completed, how much time should be there before ventricular contraction. So all those intervals, we know the normal range, and we compare that uh, with the patient's intervals. So we see this way the time. So this way is the time or interval, you see here. That is one thing we see, different segments or intervals. Another thing we see the strength of contraction and relaxation, that is the amplitude, the height of each of these. Okay, what is the height or amplitude of this? So we see this way in interval or time, and this way the force of contraction or relaxation. Okay, so if you see here, this is very big because this is ventricular contraction. Now if you see someone's ventricular contraction is like this, that means what? The amplitude is much shorter than this one. That means the ventricle is not contracting very forcefully. If you see someone's P is missing, that means atrial contraction is not occurring, right? If this one is weak, that means ventricle is relaxing, but weak ventricular relaxation. So those are 2 things we need to see and compare with the normal person, and make sure that the functions are normal. Here you can see those different events of EKG. This is P. You see from SA node the signal is depolarization is going to the atrial wall, right? So atria here. So P is seen when atrial depolarization, orange or yellow color is showing depolarization and red is showing repolarization here. Okay, so if you just know that, you will understand. This is depolarization, this is repolarization. So you see atrial depolarization is occurring, that means P wave is being formed, and then atrial depolarization is completed, so P is completed. Now the tracing you see here. Then after that, ventricular contraction, you see ventricles have started to contract, yellow color, so you see ventricular contraction here. And at the same time atrial relaxation, and which is very weak. You remember I said it is buried because they happen together. You can see that here, atrial relaxation and ventricular contraction happening together, and this one is very powerful, strong, right? So that's why you see this one. Then ventricular depolarization is completed. So this one is completed. Now the trace is here, and then ventricular relaxation is started here, right? So you see the T, the formation of T here. So now relaxation is completed. That means T is completed. So the whole thing is called the cardiac cycle. Okay, from the beginning to the end. And that is one cardiac cycle you can see in the EKG, three components. So let's stop here.